Καλησπέρα κυρίες και κύριοι και καλώς ήρθατε για άλλη μια Κυριακή στην εκπομπή μας Θέματα Υγείας. Συνεχίζουμε και αυτή την εβδομάδα με τους εκλεκτούς καλεσμένους μας από το London Sports Orthopaedics, την ιδιωτική κλινική του Λονδίνου, στους οποίους έχουμε αφιερώσει ή μας έχουν αφιερώσει 6 επεισόδια σχετικά με διάφορες αρθρώσεις και συνδέσμους και παθήσεις τέλος πάντων μεγάλων αρθρώσεων, τα οποία συζητούμε και προσπαθούμε να δώσουμε πληροφορίες για τις νέες θεραπείες, νέες μεθόδους, χειρουργική αποκατάσταση και πολλά άλλα. So tonight I welcome Mr. Henry Atkinson.
Hi.
Welcome.
Thank you very much.
That's very kind of you to come and join us tonight and discuss about knee problems. I'm particularly interested tonight, after my injury, about the knee problems. So, Mr. Atkinson is a consultant orthopedic surgeon at London Sports Orthopaedics, part of this special group we have met already, and he's also a clinical director for surgical services at North Middlesex Hospital. Tonight he's going to tell us about the knee joints, problems, cartilage damage, treatments, therapeutic options, the ligaments, the meniscus, which is a common problem.
Absolutely.
Knee arthritis, and really impressive new therapeutic treatments and surgical interventions. We are having all our attention dedicated to you.
Okay, well, thank you very much for having me.
Our pleasure.
As you said, I'm part of London Sports Orthopaedics, the third instalment, so you've met a couple of my colleagues before.
Yes.
So we're a group of surgeons, there's a few sports and exercise physicians, and we work as a big team.
Nice.
And there's about 17 or 18 of us at the moment. And it's nice, it's a nice environment.
Yeah.
We have very good facilities and state-of-the-art technology for investigating. And we're very lucky that we work in London Bridge Hospital, which is, again, a state-of-the-art facility with kind of the best equipment we can get hold of. So we're quite honoured to be there. And it allows us to do cutting-edge treatments. So some of the treatments I'll talk to you about are the standard treatments that we use for our standard patients in our local hospitals. And some of them are some of the newer things that are currently on the market or becoming available in the UK.
It's impressive. I visited you in June when we first discussed about doing this serial of episodes in the new season. So I hadn't finished the previous season last year when I visited you, and I was impressed. The kind of investigations you do, the MRIs you have, all these investigations, which you find in NHS services, but not as much, and the settings you have are really impressive.
Yeah, so we're lucky.
Really high quality.
We can investigate people almost immediately, so you can get a scan within a couple of hours, and they're fully reported within 24 hours. So people want to know what's wrong, and they want to know the pathology, and don't want to hang around for weeks and weeks, which is sometimes the case elsewhere. And we also have a 3 Tesla MRI scanner on site, so that allows you to do something called chondral mapping. So that's using some new technology, using Degenerative, which allows you to look at cartilage in a very, very fine detail. And it's almost as good as actually having a look inside at the cartilage. So when we're having a look through keyhole surgery, we get an idea of the texture of the cartilage, how much damage there is, and you can almost do a virtual keyhole operation now using the software. So that's quite amazing.
That's really true, and what is impressive, you have a very good rehabilitation team. Your therapists are very good. I was toured in their settings, and when people exercise, because you do an amazing job, a difficult job, you do the operation, but rehabilitation is a very important part, and you have a very organized team.
Yeah, and also we're very lucky that in the surrounding neighbourhood we have dozens and dozens of physiopractice groups, and that really is a key. I mean, it's important you touch on that, because what we do is only one component of a treatment path. And I mean, it starts from the very beginning, from the first diagnosis all the way through to, when people get back to sports usually, or an active life. But the physio and the rehab is a massive part of that. And we don't usually, I mean, I compare and contrast my NHS practice and private practice, and we don't really always have the same resources in the National Health Service.
Correct.
And so particularly with things like rehab, it sadly, it kind of reflects on outcomes. And you do see the same patient groups doing so much better with the right kind of rehabilitation. But Anyway, so onto the knee. So
Yes.
basically the knee surgeons will like to tell you the knee is the biggest joint in the body and it's the only important joint in the body, and everything else is actually not particularly relevant.
What
It's not
about
quite true.
hips? I think your hip colleague will be annoyed.
No, absolutely.
No? Okay.
But basically we have a general training where a lot of people do a lot of work and get experience in many different parts of orthopaedics, but then we'll become more and more subspecialized
Yes,
as you
true.
become more senior. So talking about the knee, well, the knees, if you look at it very simplistically, is almost a hinge joint. It doesn't really work like a hinge, it rotates as well, but it's simplistically made up of two bones, a small bone on the front as well called the patella, and it articulates on cartilage. So that's the cartilage gristle made of hyaline cartilage, which is very, very hard and very, very durable, and has a very low coefficient of friction. So basically it wears very, very slowly, more slowly than any kind of material we can make artificially. And then between the joint's surfaces are two meniscus cartilages, which are shock absorber cartilages, a little bit like a tire in a car. And so together that helps to cushion the load as you're doing sports activities and through the range of movement. And then you have ligaments on the sides called collateral ligaments, and you have ligaments at the front and the back called cruciate ligaments. And together it all forms the knee joint. So you can damage almost any part of the knee, and you yourself have personal experience recently having sprained your knee, hopefully only.
Yes.
And these things, dancing, yeah, very skilled dancing, I hear.
Very skilled dancing indeed.
And a lot of the soft tissue injuries settle down over about 6 weeks, and
True.
you can manage them expectantly. And unless you're having big mechanical symptoms, you can leave things be. So generally, if someone has a sprain, they develop acute pain, they develop some swelling, and that can be managed through things like icing, using compression bandages, early mobilization. So again, that's where physiotherapy is helpful. And that's to keep the joints moving, to stimulate the muscles. The worst thing is if things stiffen up, because then you're not only fighting against the injury itself, but also you're trying to deal with the stiffness that's come as a result of that. And then you can take things like anti-inflammatory painkillers as well, which help to potentiate movement. But a lot of things do settle down. But what we're going to talk about is things that don't settle down, or when there is more significant damage, and the kind of things that we deal with.
You need to intervene to operate.
Absolutely.
Yes.
So the first illustration that you can see behind you is just a picture of the knee. Generically, it shows the joint surfaces, the meniscus cartilage which sit in the middle, collateral ligaments on the side, and the cruciate ligaments at the front. And if you just keep that sort of picture in your head, it becomes a little bit easier to then kind of visualize the different parts that we're going to go on to. So one of the common things that happens is people damage the joint surface cartilage. Now, the extreme of joint surface cartilage loss, where there's no cartilage and you have bone on bone, that is arthritis. But it's a spectrum. You don't suddenly wake up one morning with bone on bone arthritis needing a joint replacement. There's a whole gradual process that gets you there. And it starts off with some minor damage to the joint surface, which gradually becomes bigger and bigger, and you end up with then patches where there's missing cartilage, and gradually that increases in size.
So that will happen mostly to elderly people, or over a specific age. It won't happen to young people that much.
Well, it starts when you're young. In fact, if you have a sporting injury, that might be the precipitating factor for the focus for where the arthritis commences. But you're right, it's a kind of a time-based thing, and actually the longer you are alive and the more active you are, the more likely there is that the joint surfaces will gradually get damaged, and eventually the end point is arthritis. And you'll meet people along the way at different stages, but in general the average age of someone having a knee replacement, for instance, in the UK at the moment is 64 years. And you'll be having people from their 30s all the way up to their 80s, but the peak is in the mid-60s. And it's getting gradually younger. What we're finding is people are getting arthritis younger.
Why?
And we think the factors are that people are heavier, so certainly our population is heavier.
Obesity.
And more active. It seems a kind of paradox.
Yes, but, exactly. Because we tend to be more and more active. I became more active the last few years. I exercise a lot. And I have more problems, which is, it's a vicious circle, so unfair. You exercise, you become more fit, and you get problems.
It is. I mean, exercise is not good for the joints, no matter what anyone tells you. Really? But actually, if you stay active, it keeps keeps the muscles in good balance, and the key is to keep your muscle strength up. That protects the joints, but not overloading the joints. And I think these trends where people are doing a lot of extreme sports, and people in their 30s in particular now taking up marathon running and triathlons and all these things, actually you're just going to start injuring yourself more and more. And you need to find a balance. So I think anything extreme is obviously bad, like everything in life. Everything, you know, within reason. But obviously coupled with being heavier and being more active, it means that the joint surfaces wear out, and that's we're seeing across, you know, the whole body, all joints affected in the same way. And as a result, we're now doing more and more joint replacements. It's expected that this year we'll do about 100,000 knee replacements in England and Wales.
100,000?
Yeah.
Unbelievable.
Yeah.
Huh. So at least we are lucky we met you and you joined us in the TV program. Sort of, at least we will be looked after. That's a relief.
Right. But we obviously try and avoid arthritis, and if we can do things to nip things in the bud and potentially repair things that can be repaired, and then also help to protect against recurrent injury, then that's the key. Because obviously prevention is better than the cure. And particularly with knee replacements, the cure is sometimes not a perfect cure, because the knee replacement doesn't replace your knee with your knee. It replaces it with a metal and plastic implant, which isn't really the shape of your knee. And actually that's why a large proportion of people has...
It's a foreign body, actually.
It is. But I think it's partly the fact that it doesn't really fit, and biomechanically it doesn't really work as your original knee did.
Of course.
So the starting point for knee arthritis is cartilage damage. So in illustration 2, you can see this is a keyhole operation picture of some cartilage that's basically started peeling off. And this is usually the result of direct trauma. So if someone bangs their knee and it hits the ground, or if they have some other kind of direct trauma, then often the cartilage gets damaged. And when we go inside, sometimes it really just peels off, and the underlying bone is exposed, and that's a bad defect. But actually sometimes it ends up with just a little bit of thinning of cartilage, and you can probe it, and it becomes, initially from being, instead of a hard frictionless surface, it becomes a little bit fluffy, and then it starts to break down. You end up with cracking of the cartilage, and then bits start flaking off, and then you end up with bigger and bigger patches where there's bare bone. The next picture shows a picture of a kneecap with some cartilage again that's starting to flake off. And basically, if you're not careful, that small piece peels off and it becomes a bigger piece, and then before you know it, there's less cushioning in the joint. So one of the things we do is something called radiofrequency chondroplasty. So in this next illustration, on the 4th picture, you can see that we're using electrosurgery to actually smooth down those flaps of cartilage. And what that does is it helps prevent those flaps from becoming bigger flaps, and also it stops the shedding of little bits of cartilage, which is actually what causes the pain.
So there is no way to stitch them somehow?
Not for things like this. And cartilage itself is fairly inert. It's almost dead material. It's basically cells within a matrix, and actually it doesn't regenerate. And that's one of the problems we have actually in the world of medicine at the moment. We're very good at creating similar tissues, but at the moment we can't recreate joint surface cartilage. But there's constant work. I mean, there's a lot of work with stem cells at the moment. We're actually running a project through London Bridge Hospital now where we're using stem cells from the bone marrow.
Stem cells are used everywhere, in cardiothoracic surgery, now in orthopaedics. So maybe in the next decades we will get there.
Yeah, I envisage a time where actually we can 3D print bone and have cartilage basically stuck on there, real hyaline cartilage, which we then seed with your cells, so it becomes living with time. And we then might be able to crack the arthritis problem if we can actually shape joints to fit you and have some sort of biological solution rather than metal and plastic. And the rate technology is evolving. It wouldn't surprise me if during my working career that this becomes a reality.
Amazing.
But the problem at the moment is we don't really have any control over stem cells. We don't really know what causes them to differentiate. So changing from a pluripotent cell, which can turn into anything, into something that grows cartilage in particular, or bone, or ligament, or tendon. And it's a sort of pie in the sky hope that by taking stem cells and just injecting them into an area, that they know what to do. And I think there's a lot of sham treatments out there at the moment, and you need to be aware, and your viewers will need to just be conscious of the fact that actually it's not yet a proven technology, and a lot of the time you might reach out for things which sound exciting, but actually there's not really that much evidence to support it at the moment. And
it will take years, obviously. You have to experiment a lot to get approval.
Absolutely.
But it's promising. At least you know that you make steps forward. It might take years, but you will save joints in the future.
Yeah. And actually, if you see every 5 years, the technology changes so much that actually it gives a lot of hope to people suffering the pain of arthritis, that it won't necessarily just be chop it all out and put a metal and plastic implant, which unfortunately is our best technology at the moment. So for the minor cartilage damage, we smooth down the joint surfaces using electrosurgery. We also have little shaving devices, which almost like a hoover, which can take out the kind of loose material. But sometimes you end up with very, very big isolated areas where there's full thickness cartilage loss. So in the next picture, which is the fifth illustration, you can see this is a direct trauma. So someone has taken a direct impact during sport, and you can see there's a lot of missing cartilage there. And in fact, this was even worse because the cartilage was then floating around and causing a loose body phenomenon. So the patient was having pain and locking.
Is there a way? Are you going to tell us how you can fill in that gap? Is it a possibility?
Yeah. So some of these lesions you can actually repair back. So sometimes if it's not just cartilage but there's a little bit of bone attached to it, bone heals very well. We actually fix them back and use little drill holes and bioabsorbable pegs. But this particular illustration on 7 shows a detached cartilage fragment, and the bone you can see underneath that is fairly intact.
Yes.
So what we do with this is we can microfracture it, so that's where we drill the bone, and that in fact releases some cells which you can think of as stem cells. And those stem cells lie within.
Osteoblasts?
Well, it's not really. These are kind of multi. Pluripotent cells they're called, or mesenchymal cells, but they can differentiate into cartilage making cells, fibrous tissue making cells, or bone making cells, depending on the environment they're in. So what this type of technology does, which you can see in picture 8, is that it causes the bone to bleed, and in that blood are these cells which then sit within the blood clot, and then they differentiate into a scar cartilage. So what happens there is it fills the gap and works reasonably well as a kind of substitute, so that people can then, it helps with pain, and in fact it has good results. 80% of people are still doing well 5 years after just microfracturing. And the benefit of this type of surgery is you can do it while you're doing the keyhole operation. It's free. You're there doing the operation already, and what you do is you just bang a few little holes.
So it's an induced fracture, trying to create these cells from the bleeding to differentiate and cover the gap, and that can last up to 5 years, and that's
or more.
Or more.
Yeah. So the 5-year results are reasonably good, and actually comparable to some other types of cartilage grafting technology. So the next slide, this is a different kind of cartilage grafting called Mosaic Plasti, and this is where we move cartilage and bone from one side of the joint, so sometimes from one part of the non-weight bearing surface of the joint to another, or sometimes from a different joint to the one you're treating. And this has been used more historically. The problem with this type of technology is that, one, it's quite invasive, so you're damaging potentially another part of the joint or a different joint completely. But also, two, the cartilage is not the same thickness, and so it doesn't have the same biomechanical characteristics. And so what happens there is it doesn't really work in the same way. But this also uses the patient's own tissue, so it's one of these things where actually there are no problems with infection and rejection of tissue and things like that, and it's free because you're using it from the patient. But things then moved on.
What you call it is not something a foreign body, so you don't have this. You don't have any evidence of the organism refusing to.
Yeah, there's no sort of rejection issues with this sort of thing. Okay. But what we've moved on to is different kinds of cartilage grafting now, where we actually take a material and actually stitch it in or glue it in. And for probably the last 10-15 years, there's been a technology we've been using called AC or MACI, where we've taken cells from a patient's knee, we've grown them in a lab, and either put them on a mesh, or into solution, and then we basically fill the gap. Okay. And that has similar results actually to microfracture. The results weren't particularly better than microfracturing, which is a shame. And also this type of surgery is quite expensive because you're growing things in a lab. So over the last 5-6 years, there's been a further evolution. So we're now using something called chondral tissue grafting. And we now have results from about 6 years of using this type of tissue. So it's an absorbable mesh, a bit like fuzzy felt that you have as a kid, that kind of, playing with, stick-on animals and things like that. And actually what you do is you then cut the felt to size, the size of a defect, and you microfracture, so we drill the bone, but this fuzzy felt then captures the cells so that they lie within this matrix, and it's a much more stable environment for them. So that kind of cartilage grafting actually has better results. So we're looking at 85 to 90% doing well after 5 years.
Okay.
And this is the technology we're now adding stem cells to as well. And we don't know whether there'll be better results or not, but it's a step in that sort of more biological
the future will tell us.
Direction.
Do you do this operation, and how many times do you separate it? Because do you need to prepare that? Can you do it during the surgery, the repair, or do you have to do one operation, then grow the material, go back, do another operation?
Yes, that's a very good question. So with the MACI, where you take the cells, you grow them in culture, and then you come back another time, that's 2 operations. And that's one of the negatives about it, and it's expensive. The chondro tissue grafting, often the patients will have had keyhole surgery before, and usually it's for a sporting injury or having had the meniscus trimmed or something like that.
Diagnostic mainly?
No, not really. No, we don't tend to do diagnostic knee arthroscopies.
You don't?
And one of the benefits, as I was saying earlier, about the MRIs are so good now that actually you have a good idea of how bad things are before you go in. There are occasionally times where you do diagnostic, but that's really when there is no diagnosis and you're still sort of scratching your head and you've excluded almost everything else. Because actually when you visualize tissues, it's the best way of testing them. But it's to do an operation where you don't have an intention to do some sort of treatment is not. My philosophy is that
less invasive.
Don't really do that. Right. But these are patients often we've identified have a cartilage defect, and it's planned in advance that they have this. And certainly you have to take their blood at the very beginning. So it's quite clever. We take a patient's own blood, we spin it in a centrifuge, and it produces something called platelet-rich fibrin, which acts like a tissue glue, which we then use to glue in the mesh.
Unbelievable.
We also then take the bone marrow, we basically drill into the bone marrow and take blood again, and we spin out the stem cells from there, and that's what we're then putting into the mesh. So it's using the patient's own tissues and own cells, but actually using some technology, using the mesh as well. And this is really for people with very, very localized defects, probably the size of your thumbnail, maybe slightly more. This is not the technology we use for people who've got widespread wear and tear in the knee. It doesn't really work with that. Though in the States there are some people who are actually using it on end-stage arthritis as well. But I think the jury's out as to whether that's kind of.
And maybe the financial possibilities are different because everything is private there. I can't believe chondro tissue graft and all this do not happen at NHS, do they?
No, but there are some centres that are doing it. And actually, funnily enough, chondro tissue grafting is not that expensive. The graft itself, I mean, it's all relative, but the graft itself is less than £2,000. And actually, when you look at other technologies, MACI and AC, which we're looking at sort of £9,000 or £10,000 for the treatment, this is a lot cheaper. And in the context of comparing to, say, joint replacements, which are anywhere between about £7,000 and £12,000, £14,000, depending on the types of implant, the environment, and where it's being done. This is actually, it's not so expensive relatively, but it's not free at all, and it's an additional cost that the health service has to bear. It's
absolutely impressive what you can do, how you can use grafts and tissues and blood from your own organs to fill in a gap and repair, correct something in another part of the body. It's absolutely, I am speechless. I didn't know that we have, obviously because I don't deal with surgical that much. I receive some letters in the surgery, but you see, mainly they're arthroscopy. I refer easily for MRIs. I'm not the kind of doctor who says, no, cost effective, I don't send. I know if there is a problem, there is no other way to diagnose. But therapeutic options, people are desperate. We have a lot of young people going skiing, exercising a lot, and the rehabilitation takes too long, and we don't have therapeutic options. And these £2,000 in London, it's approachable, especially with those with private insurance. They can do it.
So I mean, this is certainly an option and very promising for the future. And watch the space basically, because things are evolving all the time.
What successful rates do you have? I mean, what possible, if somebody else can say, well, how long do you think this is going to last? I'm young, can I still exercise after that? Can I do my activities?
That's a good question, because actually the reason they've been injured is because they've been doing exercise and sports. And as I said before, I think it's finding that balance. I think all these technologies, and I'll talk very briefly about something called meniscus transplantation, which is another possibility. These are not treatments to allow you to go back to trashing your knee again. It's a bit like, and one of my colleagues uses this analogy a lot, but it's a bit like an alcoholic who has liver failure, who has a liver transplant, and then the patient says to the doctor, I've got my new liver, can I go out and drink again? And you think, well, you know, that's not the point, and yes, you can, but you know, that's what led you to the problem. Or a lung transplant patient saying, can I smoke again? And you think, well, you know, this is there to improve your quality of life, to get you back to being active, but not to give you a license to go and do exactly the same thing all over again. Though you probably could, I think it's inadvisable. And particularly a lot of these treatments take a long time to recover. I mean, if we're doing bone realignment surgery, we're doing cartilage grafting, meniscus transplantation, these are rehabilitations for 9 to 12 months. So it's a big investment of your time. I mean, you're active during that time, and in fact, you're only inactive for the first 6 weeks or so. But actually, you know, it's a big commitment of your time and you know, recovery. So to then think, well, okay, let's go back and you know do the same again, which I think is mostly inadvisable for things like that. For things where actually I would recommend that you do go back are smaller things. So things like meniscus repair surgery. So people have a tear of the meniscus and we manage to repair it. So basically the shock absorbance is still intact. Or ligament reconstruction, which allows you to then have a normal functional life. And I mean, there'll be countless numbers of your sporting viewers who've had, you know, sporting injuries, basketball, football, etc., who have ACL reconstructions and do go back to sports and can play at a high level. And the media is full of stories of players who, you know,
that
who
was
go
my
back.
Next question. You have a lot of athletes, and I believe in London Sports Orthopaedics, that's a big proportion of your patients are
It's a
athletes.
proportion. It's not. We treat active people of all ages, and actually, it's not kind of an exclusive, you know, venue just for people who do sports. Most of them are recreational sportists. We do have some high-level athletes, and their demands are slightly different to kind of normal folk. But we get a lot of people with degenerative conditions. A lot of our patients have joint replacements done within the group in our peripheral hospitals, and it's not restrictive. But it is for people who are suffering symptoms who want to return to an active life, and it's not restrictive in any way. And that's across all the subspecialties, whether it's spine or shoulder or ankle or whatever.
And the meniscus tears are quite frequent, I suppose.
It's the bread and butter of a knee surgeon's practice. I mean, these things are very common. And in fact, a lot of people tear their meniscus without really much trauma. So you can actually twist in bed and tear your meniscus. I had a lady who had reached to get the ticket out of the ticket machine going to a car park and tore her meniscus just twisting like that. I mean, it's quite an amazing kind of mechanism.
Indeed.
Because when you're younger and the tissues are stronger, it usually takes a pivoting or twisting injury to cause that. But actually, as you get older and the tissues become a little bit less resilient and less firm, what can happen is it can just tear. You can squat down to go into the low cupboards in the kitchen, for instance, and you know you tear your meniscus, and before you know it, you've got pain and locking and a bit of swelling. And so it's very easy to happen.
Routine, it can happen anytime.
No, absolutely. But with meniscus tears, the commonest thing is to do nothing. So actually, most of these do settle down. So you get a lot of inflammation when you tear a piece of tissue. But the bulk of these are minor tears, and in fact in older patients a lot of them are what we call degenerative tears. So they're tears where the tissue just is less strong, less cushioning, and so it's more likely just to kind of split, a minor split. And once the swelling and inflammation settles down, a lot of people get back to normal. And I think it's always worthwhile trying to rehab these patients. So once you know the diagnosis, to give physio a go, because actually physio can sort out the majority of these problems.
True.
There are some tears which don't, and some tears which are called displaced tears, where actually the meniscus flicks and gets stuck in the joint, or something called a bucket handle which flips over and gets lodged within the notch, and they don't repair themselves, and they carry on causing mechanical obstruction. And those patients often present with a locked knee. So we see these patients fairly frequently coming through A&E. GPs often see them after 5-6 weeks. If things haven't got better, they then book an appointment with the GP. And these patients actually do need surgery because nothing else is going to make their knee better. And what we then try and do, if it's a young active patient and if it's the right sort of shaped tear, is to try and repair it. And what we do is we put stitches across the meniscus to basically hold the tissues together. And even though the meniscus itself is mostly not living tissue again, the periphery does have a blood supply and there is some healing potential. And certainly in a young person, you try desperately to try and repair the meniscus where possible, because it means that they have more shock absorbance within the knee. So to give the car analogy, if you've got a tyre, you've got a puncture or a blowout, instead of taking the tyre off or removing half the tyre, which then leaves the wheel to kind of grind on the road, if you can try and repair it, and this is fixing a puncture rather than putting a brand new tyre on, then it leaves the car driving kind of in a straighter way. And actually, if you can do that, then that's better for the patient.
You can go a bit further, and God knows how long.
Absolutely, keeps another 20,000 miles on their knee. But in situations where things are very bad, so you have very little meniscus left, almost no meniscus left, and sometimes these are patients who've had several operations, then they've got very little shock absorbance within the knee. It is possible now to do something called a meniscus transplant, where we take tissue from a deceased person who's donated their organs to medicine, and the same way you can donate big solid organs, you can donate tendons and bone. And
I didn't know that you can take cadaveric sort of tissues. I didn't know that they give them as well.
Yeah. You'd be surprised, you'd be amazed at what, it's a bit macabre, but there are many parts of the body which are very interchangeable, and the benefit of these types of tissues and bone and cartilage and tendon material is that actually it's relatively cell-free. So what happens there is it's obviously bio-cleansed and slightly irradiated for kind of for sterility's sake, but you can virtually take tissue from one person and put it almost straight into another person once it's been decelled. And because it's a matrix, it's almost like a protein that you're putting in, a bit like rope. You're taking rope from one place to another. You can actually, we could use your tissue on me and my tissue on you without any kind of reaction.
So it has to be a young person? No.
It just has to be healthy tissue. So generally the donors are younger, but actually we don't have a choice when we're the end user of the age of the patient. In fact, we don't really know anything about the donors at all. But they're all quality tested. So if it's diseased tissue, so it's obviously someone who's had tendon injuries in the past, or the tendon looks unhealthy or mechanically looks unhealthy, they wouldn't use it. So yes, you're right, younger patients tend to be sort of better donors, but it's not so exclusive. And in fact, a lot of bone is donated by older people, and some living as well. So for instance, if you have a hip replacement, the bit that gets chopped off is often donated to the British Tissue Bank, and there's a bone bank which which cleans it, and it's fresh frozen. I learned
too much tonight. I feel a bit stressed that I'm left behind. There's so much going on around me in the medical world, and I was not aware. So if somebody dies from any condition, heart condition, lung condition, cancer maybe not, it would be tricky. How do you know the cartilage situation, how the soft tissue looks like, so they can donate?
So basically, when you agree to be a donor, you agree to what tissues you have removed.
I'm a donor, so they can just check after I die and take everything they think is suitable for them.
I don't know what the legal situation is in the UK at the moment on when you sign up, whether they can take everything or whether you opt out of certain tissues. I know a lot of people exclude eyes and other things like that, but on the whole, almost anything is, if you've agreed to that, then any tissue that is useful can be used. And
the people who have hip replacement, they offer the piece of the bone which is chopped off, then they would throw it. Is it used for research?
No, it's used for clinical use usually. So
even from elderly people?
Yeah, so there's a lot of situations where we need bone graft, and there's a lot of trauma situations where you have broken bones, or situations where, particularly in things like foot and ankle surgery, where you're trying to fuse bones together, where you need additional bone in situations. And actually, sometimes synthetic bone is as good, but sometimes real bone is better, because actually if you can get something to match, so for instance, I sometimes do something called bulk allograft transplantation or grafting, where you take bone with overlying cartilage and you take it from one joint. So for instance, if you were doing a big graft of, say, the end of the thigh bone, where you've got a big defect and you need to, bolt something back on again, you would get a tissue match for that. So you'd actually ask for an anatomical piece of tissue which was the same shape, same size of patient dimensions.
So it can match.
Yeah, and then you basically cut the block out, which would then fit as best as possible. So that's one use potentially, but often we use morselized bone grafts. So what we do is we take the femoral heads, which are the kind of the commonest piece which is available in the tissue banks, because there's a lot of centres which collect the kind of the specimens from their hip replacement patients, and there's an agreement, and the patient needs to be aware of that beforehand. And not all hospitals do that. There's only certain hospitals that have feed into the British Bone Bank. But the commonest things we use are for the femoral heads, and actually you can cut it down into lots of different shapes for use all over the body, or you take the middle part of the head, so not the cartilage part but the bone which is inside, and you basically grind it up into lots of little kind of mushy bits which you can then push into defects.
You have specific people doing that, preparing that for you, I suppose?
No, unfortunately not. No.
You do that?
Yeah, I get the thing arrives frozen. It's frozen in liquid nitrogen. We let it thaw, and then during the operation we have a separate table where we prepare it. So it's quite a lot involved.
So you become a sculptor as well?
A little bit. Yeah.
Oh my
That's very
God.
generous. Sculpting.
Wow.
Yeah, I guess it is sculpting of a sort. But we have power tools, and we have drills and all sorts of things. So it makes it actually quite easy. So soft tissue is a similar sort of thing. So where possible and where the funding is there, again, if you had a ligament reconstruction like an ACL, so the standard way for the average patient is to take your tissue. So we take tissue from a different part of your body to then reconstruct the bit that's missing. So the commonest procedure now in the UK for an ACL reconstruction is to use one or two of your hamstring tendons. So usually from the same side, we make a little cut just further down along the knee, and then we put a stripper in which basically rips out the hamstrings. We then make it into a kind of a rope, and then we drill holes in the bone and actually pass that graft through.
And you stitch it, kind of stitch it, and you tie it in.
Yeah, exactly. We make it into a very, very strong material. The problem with that is, if we're taking tissue from you, we're actually causing damage to you to take the tissue as well. So it's not completely innocuous. So one of the things that happens is if you take hamstring tendon, it leaves your hamstrings permanently weaker, between about 10 and 15%. Now the average person like you and I, we wouldn't really notice that, because actually our hamstrings are poorly developed. I'm assuming yours are, but actually you're a professional dancer, so possibly they're good. But most people wouldn't really notice that sort of deficit. But if you're a high-end athlete, so you're a sprinter in particular, you would notice that your top speed would be less. So one of the ways around that is to use donated tissue. The other uncertainty with using your tissue is, believe it or not, the tendons all come in slightly different sizes. So you might be a very strong person but have very skinny, short tendons. And certain techniques you need to have very, very long tendons when you're reconstructing an ACL. And you can sometimes have mismatches where you don't have enough tissue, or when you make the graft it's just a little bit skinny. And actually if you order the graft, you can actually order the dimensions, the size, the length and the width for the patient that you've got. It's almost like going to a catalogue and saying, I'll have, a size 8 with this, and so that whatever arrives is going to fit your patient.
Yeah. I'm speechless.
Yeah. But it is expensive, and the graft again is about £2,000 for the graft only. Itself. Yeah. And so actually, if the funding is not there, then you have your own tissue. But in the revision case, so when people come for a second operation, when they've obviously already used up their hamstrings, then you can either take the graft from their other knee, which I think is even more crazy, because you're
left without.
You're damaging a good knee to help a bad knee. And there, my practice is to try and get allograft wherever possible. And it works, and it works very well. And actually, the most recent data shows that it's probably superior to using a person's own tendon. And the risk of things like infection, and there is a small risk of infection, so like with every operation, but specifically for allograft, there's a small risk of things like hepatitis and HIV transmission, even with screening, and it's estimated to be in 1.6 million. So it's almost zero. Yeah. It's as close to zero as is medically possible. So actually, you know, the chances of that happening are infinitesimally, well, not quite infinite, but very, very small.
Very small.
And so it's not really a kind of a real risk. And so for all intents and purposes, it's zero risk for that. So for ligament reconstruction, we often use allograft. Certainly in the private sector, that's my preferred choice, because the patients do a lot better, a lot quicker. They've got less pain. They don't have the pain in the thigh. They have less swelling because there's less bruising. And because of that, they mobilize faster, and actually they get their range of movement back faster, and it helps with their rehab. It still takes 9 to 12 months before you're back to sport, though, so it's still kind of an investment. Yeah.
Right. Do you want to tell us a few things about arthritis? Because I'm so impressed and absorbed, at least I can't complain, that I don't learn things from this TV show. Because, you know, it starts as a program to inform people, to guide them. Greek, Cypriot community, some people don't know where to go. They're not happy with NHS. And, you know, we all learn. But sometimes I'm really, really impressed. I feel so inexistent in that medical world with all these things that happen.
You're the first port of call. And in fact, in some ways, you're the most important doctor here, because you do the initial diagnosis, and you're then guiding. And patients see their GPs more frequently than they see any specialists.
True.
And actually, you're a good guide, and you can help the patient make a judgment on, you know, when the right time is to do things. And in fact, they're more likely to discuss things further with their GP than, you know, with a specialist. So actually, no, you're not. You're very important in
actually, I have to admit that I have changed dramatically many things the way I practice after these episodes, because, you know, meeting so many different specialists, discussing so much, and the number of the patients has increased dramatically as well, because we discuss more things in depth when most GPs don't touch some areas. Take this, take painkillers. I get into details with them because you learn a lot. It's good to learn a lot, but sometimes, you know, it just increases the threshold.
I know, but I think a GP has a very difficult job, because orthopaedics is one small specialty, and you're dealing with everything and everybody. And actually,
absolutely, every age, any problem.
It's very difficult to stay abreast with all the technologies.
It is.
But I think the key is early diagnosis with a lot of things, and then appropriate management. And I think, you know, it's not a one-size-fits-all for every single pathology, and there's many ways to tackle it. So arthritis, you're asking. So picture 19 here shows some joint space narrowing of a knee. This is early arthritis. And then when we go to the next picture in 20, you can see there's bone on bone. So there's no cartilage gristle. The bone is grinding on the bone. And in this situation, if the symptoms are there, so actually some people have a bit of stiffness there, maybe manageable pain. If it's that way, then actually you don't necessarily need to go down the surgical route. But if you're in a lot of pain, particularly if it's debilitating, so if you have pain at rest, pain at night despite painkillers, or your quality of life is extremely poor because of your knee pain, and in particular if you're stopping doing things. So if for instance you're housebound because you can't face walking 100 meters, 200 meters, you need to have this done, because actually if you're inactive, your body starts to disintegrate. The human body is designed to move, and actually though more movement causes arthritis over the longer term, if you stop moving, you put on weight, your other muscles waste away, it's bad for your heart or your lungs, and eventually it's a downward spiral. So when you're on that cusp, and my indications for knee replacement surgery are, the threshold's much lower than it used to be.
Okay.
Partly because technology has got better, implants are lasting longer, And it's a fairly predictable operation. And I think in the past we used to wait till people were in their 70s, they had to have pain at rest and at night, and those were the only indications. And the main rationale behind that was because knee replacements only lasted 10 to 15 years, and therefore if you waited till you're 75, you'd have one operation and it would last the rest of your life.
You wouldn't do another one in your 90s, maybe.
So nowadays implants are expected to last probably between 20 25 years. Now, not every implant will last 25 years, but on the whole, on global figures, and this is not just specific sponsored studies, most knee replacements last, 92% will last 10 years. So you've got a reasonable expectation your knee replacement will last for 10 years, and the majority do. After that, they start to fail gradually for many, many reasons. So I think it's not unreasonable to think that your knee replacement will last 20 years, and about 80% of people, they are lasting 20 years. And so actually, if you're in that environment, your threshold drops, which is why the average age in the UK now is mid-60s. But with the evolution of customized joint replacements, which are patient-matched implants, actually those patients do functionally a lot better. And so my thresholds come down to grey indications. So if you are struggling with activities, you want to stay active, but you can still walk good distances. You might be able to walk 20 minutes before the knee becomes very, very painful. As opposed to you can only walk 100 yards before it becomes painful. Or you can no longer do your hobbies, which are cycling or playing golf or whatever else, which are low impact activities because of knee pain. Or you're taking occasional painkillers, but you're getting disturbed sleep at night. I don't think you need to fill people up with painkiller tablets to some sort of level before you'll offer them a joint replacement. And when the arthritis is bad and it's going to get worse and it's inevitable they're going to need a knee replacement and they want to remain active before they start running to other issues, then actually a joint replacement is effective even in these sort of less kind of clear indications. So in central London I have a younger practice, and it's not unusual to do joint replacements in people in their early 50s, sometimes late 40s, whose joints are worn out. And if the funding is there, I will favour some sort of patient-matched implant or customised knee replacement, which is 3D printed to match the patient's anatomy.
Do you want to show us?
Yes, I can do. Yeah, so
a bit about it, because I think that's the most impressive. The 3D ones, again, something we're not aware of.
Yeah, so this is relatively new technology. It's been around for about 7 or 8 years. There's only one company that's actually making truly patient-matched implants, a company called Conformis. And the design team from that were actually one of the original design groups from one of the main standard knee replacements that's used in the US and in the UK. And they've sort of just moved on because they realized there were some shortcomings with that, and they formed a company. And in essence, what happens with a standard knee replacement that's off the shelf, it's not quite as bad as one size fits all, but it's a technology where the implants are made off an assumption that certain size people have certain dimensions in their knees. And believe it or not, some implants have the same implant for left knees and right knees. And obviously the two joints are completely different.
Of course.
And it's an approximation of what your knee is doing. So most of them work a bit like a hinge. Some have a bit of rotation as well, built in, but actually most of them work like a hinge. And the natural knee has different heights for the inside aspect and the outside aspect, and the kneecap glides in different ways in different patients. So to assume that everybody's knee works in the same way and will work the same way with the same implant is a fallacy. And so what we find is a lot of patients are unhappy with their knee replacements. So the statistics are around 20% of patients having knee replacements are not happy with the results. What's surprising is actually 80% assess their results as good or excellent. So even with that approximation and non-anatomical replacement, most people still do okay. So again, the take-home message is you'll all know somebody who's got a bad result from a knee replacement, but actually the majority of people have what's an acceptable result. And it improves patients' quality of life on every single metric. So walking is better, pain relief is better, quality of life is better, even with a standard implant. But it doesn't match the patient expectations. So people have an operation, think it's going to cure all their symptoms, they'll get their old knee back. And actually with a standard knee replacement, it very rarely does that. But if you are a low demand patient that's not expecting to go back to doing competitive sports or even sort of higher level sports, and you're wanting to just go to the shops and you're wanting just to be rid of the pain, then actually it is a very useful operation. What the evolution is in this is the 3D printing. So one of the big problems we have is that implants just don't fit. They overhang, they underhang, they put increased tension on some of the tissues, and the knee is not perfectly balanced with a standard implant. And what the 3D printed one does is we do a CT scan, so it takes a very detailed anatomical picture, it does a 3D rendering of that, and what the computer then does, once you've been through the engineers and we're still involved in the design of that, but actually it prints an implant which will fit your knee perfectly. And it creates cutting blocks, so you get these little bits of plastic which you can stick on the knee, which actually show you where to cut the bone so it fits the implant perfectly. And these really do fit perfectly. I mean, it's like a bespoke shoe, rather than going to a shoe shop and having 5 different sizes of shoe to choose from, and one being a bit loose, one being a bit tight, or that sort of thing.
Amazing.
And so it fits better. The biomechanics are closer to the patient's own biomechanics, and it works better. And the early studies actually confirm that. From an operation point of view, because we're not doing as much drilling in the bone to get alignment rods and so on, there's less bleeding. It's relatively bone conserving, so actually it's helpful when the implants I mean, all implants fail eventually, but when the implants fail, it's expected there'll be more bone then to have for when you're doing the second operation. And also it's more sparing to the soft tissues, so there's less swelling, less pain, less bleeding. Patients have better biomechanics, and what happens there is they're walking better much sooner. And it's not unusual for patients to drive in for their 2 or 3 week appointment. Certainly by 6 weeks, they're off sticks.
3 weeks to drive after the operation.
Yeah. And I'll see in clinic people who've had standard knee replacements and people who've had patient-matched implants, and it's almost like a different population group that you're treating. And it's sad for me that actually there are restrictions still on this technology. And it's all about funding. The implants cost a bit more, so a standard knee implant's between £1,500 and £2,000 for the implant, and a customised one's about £3,500 to £4,000 for the custom one. But in the context of the whole operation, an operation in the NHS, the tariff is about £7,000. So the implant would add probably about £2,000 on top of that. And the problem is with the health service, because you're dealing with the mass population, once you extrapolate that to 100,000 patients, that's a huge amount of money. It's billions extra, and it's billions at a time where we don't have billions spare, and everyone can understand that. But for you as an individual, it's a massive difference. And I'll give you the stats. So 4 or 5% of patients with a customized knee replacement are not happy with the results. 20% with the standard are not happy with the results. And it's a massive difference. I don't think it's a perfect solution. It's still metal and plastic. And as I was saying before, a better solution would be some sort of biological replacement. So this picture on the slide 22 shows 2 pictures, one of a traditional knee replacement, and there are bits where it's overhanging, there's a bit of exposed bone, so you end up with more bleeding, and then this is an illustration of the custom one. They're not that dissimilar. It's the same materials, it's the same metal, the same plastic, more or less, but actually it just fits better. And on the next picture, on slide 23, this is what we get given as the surgeon. So it shows you where the jigs are going to fit when you're cutting the bone, and you stick that on the wall and you follow it. It's almost like following the plan, because every single operation is different, and these jigs fit perfectly, and the implant actually fits perfectly. And I'm not just saying that; it really is. I mean, it's stunning.
So, yeah, definitely.
And this next picture, 24, this shows different sizes and shapes of the top of the shin bones, the top of the tibia. So every single one is different.
So they can fix better to the demands, to the anatomic side of each one of us. And
the last picture here, it shows the different shapes of the femoral components. So every single patient is slightly different.
Of course.
And each of these patients would probably, because it's the same more or less shape, would have had the same standard off-the-shelf implant. And you can see that there would be a mismatch one way or the other. And so it's dramatic. And I think it won't be long before this sort of thing becomes available for everybody. But unfortunately at the moment...
At least when we get older, we have hope. We have plenty of time to get there.
Yeah. And I think within the next 5 years, 10 years, this certainly will be available for the majority of people.
Even better.
So, yeah.
At least in the 20-25 years, when we will get there, many things will have changed by then.
Oh yeah, for sure.
Definitely.
We won't even recognise medicine. I mean, you won't probably even consult with people.
Yeah.
Everything will be on some sort of, you know,
robots,
special computer, deep brain or something, deep mind, where they'll be diagnosing things using algorithms, and
who knows?
You know, robots will be doing the surgery. Who knows?
Anyway, I think the human presence is something you can't. It's not a substitute for that. It's irreplaceable. It's different. The human presence, the senses, the hands, the brain, everything working towards the better for another human being, it's irreplaceable by any sophisticated super computer machine or whatever that would be. Anyway, it was the most amazing 55 minutes of episode I have ever done.
No, you can't say that.
Honestly,
it's been my pleasure to be here.
I'm so impressed.
Enjoyed your hospitality.
I think I could keep you here 2 hours talking and asking. There's so much. I had no idea personally that we have advanced so much. Many people have access to private services, so I hope many people got that message tonight, and it's good to know, because at least people who ask and they say, do you have someone desperate just to recommend someone, we know where to guide them now.
But not to belittle the National Health Service.
No, definitely.
The National Health Service does an excellent job. It is resource constrained, but things are evolving there as well. And you know, this gives people hope that actually things are getting better.
Of course.
And I think the days of just chopping bits out and then letting kind of your joints deteriorate are gone.
We can have the arrangements when NHS can cover the 6,000, 7,000, 8,000 pounds knee replacement, and the extra 2,000 bit can be added on the top by the patient privately to get a better piece of transplant or implant. So we are expecting better days. I'm sure we are. Thank you so much for coming. I wish you can come back in the future and tell us a bit more and talk about rehabilitation, maybe.
Yeah, absolutely.
And other things. It would be very, very welcome in this
My pleasure.
studio. Thank you very much. I'm very impressed, and I wish you the best now. And I'm really grateful for all the things you told us tonight.
My pleasure.
All right.
All the best. Bye-bye.
Ευχαριστούμε πάρα πολύ που ήσασταν μαζί μας. Ελπίζω και εσείς να ενθουσιαστήκατε όσο και εμείς με όλα αυτά τα σπουδαία που ακούσαμε, και τουλάχιστον υπάρχει ελπίδα, γιατί η επιστήμη κάνει άλματα πραγματικά. Ραντεβού την επόμενη εβδομάδα, πάλι με ορθοπαιδικά προβλήματα. Καλό σας βράδυ.